Hi, my name's Kelley Kruze, and today I will be presenting you with my study on central retinal artery occlusions and how we implemented fundus photography in the emergency departments across a health system in Northern California, and how that led to the identification and treatment of CRAO. So the key learning objectives for today are to describe how integrating fundus photography into an existing stroke alert workflow in the emergency department setting can actually address the diagnostic gap in identifying central retinal artery occlusions within the treatment window, explain why improving access to diagnostics for central retinal artery occlusions may actually impact the treatment, and identify the key components of a hub and spoke telestroke model. So the point of care imaging, ophthalmology consultation, and all the way through to treatment. I have no financial disclosures, and I leverage Grammarly and Anthropic for grammatical corrections and linguistic refinement. Central retinal artery occlusions, or CRAO, is an acute ischemic event that happens in the retina, and it can cause sudden and permanent vision loss. The challenge here is that about 92.6% of patients with sudden and severe vision loss were never actually evaluated for IV thrombolytics within the treatment window. So in eligible acute ischemic stroke patients who do present within 4.5 hours of symptom onset, they might be eligible to receive IV thrombolytics, also known as a clot buster. Those medications typically involve either tenecteplase or alteplase. Now, the challenge here is that ophthalmology for these CRAO patients is rarely available on site in the emergency department settings. So our study wanted to look at whether or not embedding fundus photography in the ED in the Kaiser Permanente Northern California telestroke network, would that improve or increase identification and potentially treatment of CRAO within the treatment window. So here we rolled out fundus cameras into the ED settings to allow clinicians to capture retinal images, which therefore could be immediately uploaded into the electronic health record for immediate evaluation by ophthalmology. Our retrospective observational chart review reviewed cases from 2018 to 2025, again, across all 21 hospitals that are Joint Commission certified for stroke care. And we leveraged our stroke alert database called MIDAS. We therefore used our EPIC, or electronic health record, to delve into the patient charts. Our population included adult emergency department patients greater than 18 years or 18 years or older greater with acute vision loss treated for CRAO, and we excluded inpatient stroke alerts patients who are pregnant or who are children. Our pre-implementation was 2018 to 2021, and our post-implementation period was 2022 to 2025. So the first step in this workflow that was implemented in 2022 was leveraging the ED fundus photography imaging, recruiting and leveraging remote ophthalmology consultation to diagnose the CRAO, and then, if eligible, giving patients tenecteplase for treating their CRAO. What we found is that only one case in the pre-implementation period received a thrombolytic. In the post-implementation period, we found that 57 cases received thrombolytics. Now, a few things to note here is that in 2020, our entire region switched from alteplase to tenecteplase as the IV thrombolytic of choice. We rolled out the ED fundus photography cameras throughout 2022, so not all hospitals received cameras at the same time. For ease of the study and for the study purposes, we used 2022 as the post-implementation cutoff. As context here for our telestroke program, in 2016, the Kaiser Permanente in Northern California region rolled out the telestroke model for stroke alerts. And at that time, we had the infrastructure to improve our door to needle times and our diagnostic access to acute ischemic stroke. The literature found that it's relatively difficult to achieve a timely diagnosis for central retinal artery occlusions. And the literature suggested that point of care fundus photography within the emergency department settings, coupled with telemedicine, could be a potential solution for diagnosis. Now, there is further debate within the literature whether or not IV thrombolytics are the preferred treatment of choice for central retinal artery occlusions. There are trials stating yes, and there are trials stating no, it provides no benefit over standard of care with aspirin. There's currently a trial ongoing right now to identify whether or not IV thrombolytics do improve treatment or they do improve outcomes for central retinal artery occlusions, but that research hasn't been completed yet. There are some limitations to this study design, including we cannot rule out any confounders around clinician familiarity with central retinal artery occlusions after the implementation of fundus photography in the ED. We only evaluated treated cases, so we don't have a true denominator here. The single 2022 cutoff simplifies that the implementation of fundus photography was actually a staggered rollout. And findings are grounded in an integrated system. They may not generalize to other health systems. Our next steps are to evaluate all suspected CRAO presentations, see how fundus photography evaluation could be implemented in a non-integrated hospital setting, and review the outcome of the revision trial, which is that randomized control trial to see whether or not IV thrombolytics are a good or not a good response for central retinal artery occlusions. Overall, our study did find that integrating fundus photography as a point of care imaging and in combination with rapid ophthalmology consult in a remote setting, that we did have an improvement in CRAO diagnosis and treatment. However, we need to see how this could be potentially replicable in other frameworks for other health systems facing the exact same diagnosis and access challenge. Here are the references, and I want to thank you for your time and for being here today.